Hello, I am Dr. Piyanat Priyanon, an interventional cardiologist from Perfect Heart Institute here in Bangkok, Thailand. I have Dr. Henry Ting with me. Hello, Dr. Ting. Dr. Ting is a interventional cardiologist from Mayo Clinic, a director of Mayo Clinic Quality Academy, Associate Dean, Mayo Clinic College of Medicine. Dr. Ting was born in Taiwan. He went to the U.S. at the age of 6. He was trained at Harvard Medical School and Brigham and Women's Hospital. And this is his first time in Bangkok. Is that right?
I'm delighted to be here. That's right. It's a beautiful country, and at the Mayo Clinic right now, it's negative 10 degrees Fahrenheit. So it's about 90 degrees warmer here, so I'm delighted to be here.
So the weather is very nice here. Dr. Ting, what do you see as the largest challenges in primary PCI in Asia?
Primary PCI is a very effective treatment for ST elevation myocardial infarction. But I think the primary challenge, or the largest challenge I see, is the rather large geography and large countries, as well as the large populations. Primary PCI, to be successful, depends on networks that communicate and coordinate care effectively. And those are the processes and structures and relationships that need to be developed. Till that time, I think there's great opportunity for Thailand and other Asian countries to use other effective therapies for ST elevation myocardial infarction. That includes early thrombolytic therapy in people who are eligible.
Right. And bare metal stent or drug-eluting stent for STEMI intervention for you?
Well, we do a lot of ST elevation myocardial infarction primary PCI interventions at Mayo Clinic. And I think the question is, if your goal is to reduce myocardial injury, reduce in-hospital and third-day mortality, then the results of plain old balloon angioplasty, bare metal stenting, or drug-eluting stenting are all fairly equivalent. The major benefit of drug-eluting stents is in the reduction of restenosis at 12 months. So that's the reason why drug-eluting stents is used in probably 90 to 95% of our cases. But recently, we've noticed that patients may not be able to adhere or comply to 12 months of dual antiplatelet therapy after drug-eluting stenting, either because of they forget, they don't want to take it, or they can't afford to. So now in the United States, we are being very, very careful and vigilant to ask our patients and families, even in the setting of ST elevation myocardial infarction, whether they can afford to take it and will be compliant with dual antiplatelet therapy before we insert or deploy a drug-eluting stent.
And what do you think is the pragmatic role of thrombectomy in STEMI interventions?
That's a terrific question. Thrombectomy means manually aspirating the blood clot from the occluded artery in the setting of ST elevation myocardial infarction. I was fortunate to participate in the recent PCI guidelines for the American Heart Association and the American College of Cardiology, and our review of the literature indicated that most patients, almost everyone who comes in with the ST elevation myocardial infarction should probably have manual aspiration thrombectomy if it's possible. We gave it a class 2A recommendation because in some cases the blood clot is very distal in a small vessel in which couldn't accommodate a manual aspiration catheter. But short of those instances, manual aspiration thrombectomy decreases no reflow and distal embolization and improves outcomes in our patients with ST elevation myocardial infarction. So I think it probably should be used most of the time.
Well, Dr. Ting, thank you so much for joining us today.
Thank you very much. And I'm really looking forward to this Lumen conference, and my personal hope is that in the 2 days here, that we are here at this conference together with our colleagues from Asia and Thailand, that the relationships and information we share will go beyond the 2 days, and that we can continue to build our relationship and share our knowledge for 365 days.
Thank you so much again.